guess. I can't tell. Okay. So I'm Aaron Cohen. I'm a professor in the Department of Medical Informatics and Clinical Epidemiology. If you don't recognize me, and this is our regular Thursday conference, and today we have Raja, who will be presenting his master's thesis work. Now I have the blurb that will tell you everything about Raja that I didn't know before I read all this. Raja holds a bachelor's degree in general science and community health studies from Portland State University and is currently a master's of science clinical informatics student in the Department of Medical Informatics and Clinical Epidemiology here at OHSU. His current area of focus is on clinical quality measurement. Broadly, Raja has interest in healthcare quality, healthcare data science, and the use of health information technology to support clinical care. In his role on David Doerr's team, he has helped provide technical assistance to clinics participating in primary care transformation projects, including targeted technical assistance around HIT and clinical quality measures for AHRQ's Evidence Now initiative, CMS's Comprehensive Primary Care initiative as well. He has also helped with the development of best practice alerts in EPIC for the Clinical Decision Support IQ Maple project, and also with the help of helping with the implementation of select CQMs in the Integrated Care Coordination Information System, and with the preparation of education materials for the Office of National Coordinator for Health Information Technology Training Curricular Grant. Raja is originally from Portland, Oregon, and today he's going to talk about his work looking at a new language for clinical quality measure, description and implementation, and comparing the features of that language with the old language and what's good, what's bad, and where we're going in the future. So with that, I will let Raj take over. I did say that in the beginning. This is his master's thesis defense. So after all this, thanks for reminding me. So after all, they'll do a presentation, then there'll be some question and answer period, then we kick you all out, and this committee gets to grill him a little bit to make sure he really knows his stuff, and then he gets to go out and wait while we all discuss and make a final decision. So with that, you ready to go? Yeah, do you need this? Or you got that?
I have this thing.
All these microphones are newfangled. We are streaming and recording, and so that's why we'll walk around with the microphone.
Okay, thank you. So like Aaron said, I assessed the benefits and challenges of clinical quality language, which is a new Health Level 7 international specification for representing logic criteria for clinical quality measures and clinical decision support. There's a lot of buzzwords there. I will hopefully define them throughout this talk for you. So in the United States, we spend a disproportionate amount in our healthcare costs, both current and projected. But Americans are still more likely to die from preventable conditions compared to residents in other high-income countries. So therefore, there have been efforts to try to increase the value of care delivered in the United States. However, exacerbating these poor outcomes and high costs is the fact that historically, our payment system has been operated under a fee-for-service model, meaning that each service or unit of care is funded individually, and so this may influence clinicians to provide an increased volume of services rather than better services. And so when we talk about increasing the value of care, we could think of this as the quality of care delivered divided by its cost. And starting in 2019, the Centers for Medicare and Medicaid Services are tying payment to performance on quality measures in a program called the Quality Payment Program. And so this program, the Quality Payment Program, requires hospitals and clinicians to report electronic clinical quality measures, or ECQMs. These are based on evidence-based guidelines that track structures, processes, and outcomes from clinical data recorded in electronic health record systems. And while the Quality Payment Program is starting to tie these performance on these measures to payment in 2019, there's actually a long history of payment programs that have required manual chart abstractions, but as EHRs have been rapidly adopted in the last 10 years, we now have these official electronic clinical quality measures that are now tied to payment. And so, like I said, these ECQMs measure quality at the population level. They're often reported at the hospital level or the practice level. and you aggregate your patients who were seen during a measurement period, usually the last year, for example. So on this slide, I define the various subpopulations that are included in an ECQM. Specifically for CMS ID 154, which I'll talk about throughout my talk, which looks at the appropriate treatment for children with upper respiratory infection. So in an ECQM, there's a denominator, which is a subset of patients whom your measure is designed to address. In CMS 154, that is kids who are 3 months to 18 years old who have a diagnosis of upper respiratory infection. You have a numerator in an ECQM, which is the subset of the denominator for whom some type of outcome or clinical action should occur. So in this measure, it's the children in the denominator who do not have a prescription of an antibiotic within 3 days of their diagnosis. And some measures have exclusions where you remove patients where there might be a contraindication or where the therapy or service is not appropriate. And so in this measure, it's children who are already taking antibiotics or who have a competing diagnosis with upper respiratory infection. And so I mentioned that these ECQMs rapidly evolved with the widespread adoption of electronic health records. And so therefore, the quality measurement community also had to rapidly develop standards to facilitate that implementation and adoption of ECQMs. And so specifically, CMS endorsed measures all have a specification in the Health Quality Measure Format, or HQMF. And these are human-readable specifications. They outline the rationale for the measure, as well as the definition of those different components, the denominator and the numerator and the exclusions. In addition, they also define the structured sets of codes and terms to define the clinical concepts, or these are called value sets. And so this is all in the human-readable specification. There's also a machine-readable spec in extensible markup language, XML. However, I focused on the human-readable specification for my thesis. Specifically, also included in the human-readable definition is pseudocode. And so this is the pseudocode for CMS 154. It represents the relationships between the clinical concepts, and it's based on a standardized model called the quality data model, which defines relationships between clinical concepts like diagnoses and encounters, for example, and it ties these to standards-based terminologies. And the goal of this is to facilitate standardized quality measurement across healthcare institutions. So to give you some more background, the context around clinical quality measurement dates back for decades, and this preceded the widespread adoption of electronic health records. So this required sampling and manual chart reviews on a sample of patient records. And so these early programs required that sort of manual abstraction and then human interpretation of the abstraction tool so that you could submit those, your performance to CMS, essentially, or to whoever was requiring the reporting. And then over time, the measures were updated to reflect new guidelines. This required new data collection techniques and implementation techniques. And then, of course, in 2009, with the HITECH Act and Meaningful Use Incentives, which resulted in the widespread adoption of EHRs, we now have even more efforts to try to standardize how we measure healthcare quality. And so now we have health IT vendors and healthcare organizations that aim to manage all these standards, and the goal is to create shareable expression logic between the sites. However, there are data quality issues around completeness and correctness and validation issues, and these apply to ECQM implementation. So that is sort of at the population level when we think about clinical quality measurement. At the patient level, this is often represented by clinical decision support, like patient safety alerts or health maintenance reminders. And the logic expression for these alerts and reminders have the same problems as ECQMs. And so early implementers realized that there needed to be this sort of human intervention and handcrafting to implement these sort of rules. So they encoded the similar to the pseudocode I showed you for CMS 154, they created if-then-else logic to represent the rules. And then in the 90s, the most popular one was called the Arden syntax. It was pretty revolutionary. They had different categories and slots And what was good about the Arden syntax was a logic slot, and so they were able to really hone in on the if-then-else logic for these types of rules, and there was some promise in the ability for that to be portable across sites. However, also in the Arden syntax was this part which was a curly brace, and within the curly brace was human-readable text that basically described to a human how to map the rules to database processes so that they could implement these rules against clinical data. And this was a problem because it required this human intervention and handcrafting to really make these things implementable. And so in the last 20 years, HL7 and others decided that the curly brace problem was not solvable in Arden syntax. There have been various efforts around creating models and standards to try to address this. However, they haven't solved it. So to this day, so this is a slide I stole from, or I'm borrowing from the ECQI Resource Center. So for those of you that have experience working with clinical data, this probably should sound familiar to you, the fact that you can't just implement an algorithm against your database. There is some mapping and there's decisions that have to be made at the local level. And so you can see here with the implementation of an ECQM, there's this cycle of conceptualizing and testing and understanding the specification before you're able to implement it. And so despite the fact that we have all these standards, which I've shown you, we have the HQMF representation, we have standards-based terminologies. There's a lot of variation across the ecosystem. We have various networks and communication channels and sets of organizations of clinical data that currently exist. So implementers have to make these decisions to map clinical data at each institution. And just in case you don't believe me, I've actually studied this variation in collaboration with Drs. Dorr and Weiskopf. And so as Aaron said in my intro, I worked with clinics in Oregon on quality improvement initiatives. We required the clinics to submit data to us quarterly. And in addition to the variation that existed at each clinic in terms of their local decisions on how they handled their clinical data, they often resorted to certified health IT to generate their ECQM data to submit to us. So some used their electronic health records, some used health IT registry systems, and some had back-end access to their systems and implemented their own queries. And then to add more variation to this is the fact that the measures themselves are updated at least annually, sometimes 2 to 3 times a year. So there has to be management of that as well. And so in Q1 of 2017, when we were collecting data, we knew that this variation existed between the clinics, between their health IT that they were using, and then we knew that about 3/4 of them were submitting a 2015 version, and 1/4 were submitting this new 2017 version. And in this version update were big changes to the logic and the definitions. And when we looked at this, what we found was that between the 2015 and 2017 versions, the performance was different by up to 5% in overall performance score, and then the denominators shifted by up to 28% in the number of patients included. We also studied implementations based on distinct value set specifications, and we altered look-back periods in separate papers, and we found the same sort of thing, that the variation in the specific criteria can really impact your performance score. And so looking back at the paper we did about the different versions of measures, the bold rows are the aggregate measures, and then the sub rows, we broke them apart to just look at specific subpopulations. But you can see that the change in performance from 15 to 17 is on the very right. It can change up to 5%. And in some cases, between the versions, the performance decreased between the versions. And so when you reduce this to a percentage, like that 5% is enough to change the amount of money that a clinic might receive for their payment reimbursement. And then focusing on the patients included, this is also important in terms of patient safety. So this is a Venn diagram looking at the denominator for patients. On the left is the patients included in the 2015 version of a measure, and on the right is the patients including it in the 2017 version of a measure. And so for this, if you imagine that the 2017 or the most updated, accurate representation of this measure is like perfect inclusion, then what we did was we took numbers needed to treat statistics, and we estimated the number of lives that might be saved if you implemented a targeted quality improvement intervention. So the takeaway for this slide is that if you have accurate implementations and standard representations of measures, you might be able to save lives and avoid harms for patients. And so this emerging standard, clinical quality language, is intended to do this. It's supposed to help with the electronic processing of ECQM logic. It's a new specification for the pseudocode. So it's replacing the QDM, HQMF pseudocode. It's intended to include more natural language descriptions, increase readability. It's supposed to have a human-readable, conceptual level language to define these measures. And so here, it's a little hard to read, and I will zoom into this and show you snippets of this. This is the HQMF quality data model pseudocode representation for CMS 154. You can see there's a lot of ands and ors here. It's like a list of Boolean logic. And this is the CQL representation. It's supposed to mimic a high-level query language. In addition to Boolean logic operators, it has other things that you might see in structured query language, for example, like unions and intersects. There are identifiers, and there's functions. So you can see that it's maybe closer to a programming language, and it's also less wordy, according to the creators. It's supposed to be less wordy and easier to interpret. And so these are from slides released in April 2017 about the trajectory for CQL. So currently, this is what the ECQM calculation ecosystem sort of looks like. This is what I've described to you. You have your HQMF QDM. The translator might be the humans at a healthcare organization, and you have to manually interpret the HQMF and then apply it to your calculation engine to calculate your measures. In the near term, and it already sort of exists, is the ELM, the expression logic module. And this is a way for, CQL is intended to be machine readable. So if you imagine that a computer could decipher CQL for you automatically and then spit out a query that you could then manually configure and apply to your data set. So it facilitates the translating process. And then thinking even further, aspirational, the CQL, ELM could sort of replace the translator or happen in parallel so that all of this could happen automatically, like across systems and between vendors. There's a common model so that you could just ingest your CQL and everyone is measuring the same way. And there has been some feasibility for this, like at Mayo, they've published a paper where they were able to do this. They translated CQL into Sparkle, which is like a graphical query language, and they use semantic web technology and as well as FHIR data model to really facilitate this. So there is some promise here. However, in the near-term future, there's still going to be this human intervention, this handcrafting of measure logic. And so what I did for my study is was assess that the benefits and challenges of interpretability of CQL. There's no current literature that does an evaluation of CQL, and so therefore that's the reason I chose to do this. My hypothesis was that CQL would be better, given the fact that it's intended to solve some of the problems that exist with HQMF QDM. So I found a framework. This is from a textbook about algorithms by a guy named Smed. And basically, I used this to sort of frame my aims. But basically, what he says is that for an algorithm, there needs to be explanations in natural language that define the different components or the substructures. And then secondly, there needs to be like a formalism or a structure to the code, to the pseudocode, so that someone can easily decipher it and convert that into programming code. So I used this framework to sort of ask my research question, which was, is CQL better, and specifically, is it better at addressing the curly brace problem, or to reduce the burden on the humans that have to handcraft and implement electronic clinical quality measures? So in short, I did a qualitative research design with a purposive sample of ECQM developers, authors, and implementers. I conducted semi-structured interviews based on the pre-seed proceed model. So pre-seed is, and pre-seed proceed was developed by a guy named Lawrence Green, who's a famous public health practitioner. And so pre-seed is a acronym for predisposing, reinforcing, and enabling constructs in educational diagnosis and evaluation. So basically, pre-seed involves assessing the community factors and behaviors and social problems, the determinants of a given problem, and as well as the factors that predispose, reinforce, or enable them. And then proceed is the latter half of the acronym, which stands for policy, regulatory, and organizational constructs in educational environmental development. So this is looking at whether or not certain programs or resources are reaching the intended populations and evaluating the behaviors. So basically, in plain English, what I did was I used this model to identify each expert's backgrounds, their experience with ECQMs, and then also thinking more broadly, thinking of the ecosystem, what they needed to help improve their ability to implement, author, and develop ECQMs. In addition to that, I also chose a measure which had specifications in CQL and HQMF QDM, and I asked the experts to review those, and then for CMS 154, and then let me know what was better or worse in each representation in their ability to look at the clinical concepts and decipher the logic criteria. And I chose this measure because it was complex, it had a good mix of clinical concepts, it had various encounter types and complex temporal facets between the clinical concepts, which are all sort of challenges when you're trying to decipher logic criteria. Of the 13 participants, 6 were randomized to be shown the CQL version of the measure first, and 7 were randomized to be shown the HQMF QDM version first. I did not just choose CMS 154 at random. I also considered other measures. These were sort of the final 4. These are all official measures included in the quality payment program. I ultimately, so this is how I did my measure comparison. I pulled out the number of data elements as a proxy for the complexity. I listed the concepts that are in them. Some measures look at medications. Some measures look at whether or not screening occurred for a certain condition. And some actually look at outcomes like lab values. And then I also described the issues of time and temporal relationships in the measures. And so I ultimately decided on CMS 154 because it was complex. It wasn't the most complex. Like there was one with 26 QDM data elements. But also it was a pediatric measure, which I thought that the experts would have less experience with. Mostly people have experience with implementing in primary care or adult populations, and so I thought it would be good if there was a measure that they might not have pre-existing experience with. So I recruited my 13 experts using a purposive sampling technique. I reached out to HL7's Clinical Quality Information Working Group. There's a CQL GitHub repository with contact information, as well as developers from CMS Measure Authoring Tool. I also had contacts that I met working on the Evidence Now initiative. But basically, the profile I was looking for was people who had experience with developing, authoring, or implementing ECQMs, people that were experienced in clinical informatics, and familiar with HQMF, QDM, or CQL. I then created an interview guide based on the pre-seed, proceed model, as well as my prior work with ECQMs and understanding the challenges. So just to review, basically I asked about their background and their role. I asked about the enabling factors, predisposing and reinforcing factors in the ECQM environment. I asked about the specific data elements that they thought were beneficial and challenging within logic criteria, and then I showed them the CQL and HQMF QDM versions and asked them about the benefits and challenges of each. And then I thought more broadly and asked them about the environment and the policy and regulatory and materials that would help facilitate standard implementations of measures. And there was no existing interview guide to use, so I had to create these based on the lit review and existing resources. And then Also, it was a semi-structured interview, so I modified the questions in light of each person's expertise or what happened during that conversation. And importantly, I piloted the interview at first with two interviewees early in the process, and I learned how to reorder some of the questions. I got some additional questions to ask, and it was just really valuable to do that. So for the analysis, I used the basic immersion crystallization approach. First, I developed a code book using the lit review and previous work based on pseudocode conventions and our understanding of some of the complex issues with delineating logic expression for ECQMs. Then the interviews were conducted and recorded and transcribed. I coded the transcriptions independently, reviewed them as a group, and then the themes were pulled out from there using the immersion crystallization approach. I used Atlas TI for the management and analysis of the transcripts and the coding. So I talked to these 13 experts. Most of them worked at academic medical centers. A few were at software vendors or contractors, and one was at a local health plan. All 13 of the people I talked to had experience with implementing ECQMs, ranging from 2 to 11 years. And HQMF QDM is about 11 years old, so and their mean experience was 6.5 years, so pretty experienced with implementation. 3 of them had experience with writing and developing and authoring ECQM specifications. And then about half of the group had experience working with CQL, and half had briefly reviewed it. And then the one person who had no experience with CQL had heard of it and sort of knew what it was. And so then thinking of the enabling factors and challenges, sort of the precede part of my interview guide. So despite the fact that those 13 people had a wide range of experiences, they all agreed on the enabling factors and challenges globally that impact ECQMs. So for enabling factors, some of the resources that were really helpful are CMS's ECQI Resource Center, which is a website which has all the measures, specifications, and logic. The National Library of Medicine's Value Set Authority Center has a list of all the codes and terms that define clinical concepts. The Bonnie testing tool is specifically helpful for validation. It's a tool that can interpret HQMF QDM and show complex representations of logic. And again, enabling factors in this context are those programs and services or resources that are that facilitate action or behavior. And then the global challenges that came up were really around the fact that these ECQM implementations require human intervention to be able to decipher the HQMF logic and then implement those against clinical data. And so therefore there are these decisions that have to be made. And then the hardest things to make decisions around are temporal relationships, navigating encounters, transforming units, accurately retrieving the initial patient population, and then issues around granularity of the clinical concepts. And so this is a particularly good quote that reflects some of the global challenges that came up consistently across my interviews. So one thing we really struggled with is trying to understand what the baseline population is actually supposed to be, or how you define the denominator. Because a lot of these measures, they'll just say within your population, people who've had at least one visit and are over 18. But they don't say what kind of visit that's limited to. And they don't say exactly how you're defining our population. So within this quote, we see that people tend to struggle with, or this particular person struggled with temporal relationships and identification of the initial patient population. And one thing, I mean, it's sort of obvious, but that came up was that HQMF QDM and CQL, they're very different. They look very different at first glance. So again, this is HQMF QDM. So it starts with the initial patient population, tells you it should be these kids 3 months to 18 years old during the measurement period. And then it breaks down the encounters, and then the denominator exclusions, which are people that are already taking antibiotics or that have a competing diagnosis, and then the numerator is people not taking the antibiotic medication. And then CQL has sort of some of these same elements, but it's in a different order. It starts with the same stuff, the kids 3 to 18, 3 months to 18. The encounters is a little cleaner, it's shorter. And then they actually have encounters and diagnoses separate as separate things, while HQMF-QDM lumps those together. And your denominator is written a bit different. The syntax is a little different, but it's the same thing. People not on an antibiotic. So here's the side-by-side comparison, and I'm going to zoom in on each of these. The different colored boxes are supposed to represent the same data elements. So for the next few slides, HQMF-QDM is on the top, and CQL is on the bottom. So this is supposed to be looking at the initial patient population. So again, here you can see one of the big differences here is in HQMF-QDM, they say the birth date is greater than or equal to 3 months, start before start of measurement period, or less than or equal to 18 years. In CQL, they actually have a function that's age in months, and they have a function that's age in years. And so they're able to just say greater than or equal to 3 and less than or equal to 18. So there's like less redundancy with that start before start of measurement period. But, people did not universally think that this was better. There was a lot of disagreement. So some of the 13 people thought that HQMF-QDM was better. They liked that redundancy, actually. And some people liked the simpler representation in CQL. With temporal relationships, it's also sort of the same thing. So here they say that the diagnosis in HQMF-QDM, the diagnosis is less than or equal to 3 days, start after start of the diagnosis. Whereas in CQL at the bottom here, it says occurs 3 days or less. So in this case, they're actually trying to use more natural language. It's less like program scripting language here. And so that is supposed to be, so some people thought this was better to interpret. It was like clear what 3 days or less meant, and some people actually just preferred it to say less than or equal to 3. And then also in HQMF-QDM, it's not included in this snippet, but they referred to just the measurement period over and over again without ever defining it. Whereas in CQL, right, this is at the top of CQL, they tell you the measurement period, in this case is January 2013 to January 2014. So some people liked that aspect. In terms of how they represented logic, in HQMF-QDM, it was just this list of Boolean operators, like a bunch of ands and ors. And so the order of things really matters. Whereas in CQL, I sort of mentioned this, they have more things you might see in SQL, unions, where clauses. They also have these like identifiers that are defined and can be reused across things. For the encounter types, so in HQMF-QDM, one thing that came up consistently is they talk about, so at the top here, it's a diagnosis that happens during a set of encounters, or a set of encounters that happen during a diagnosis. And people have trouble with this, and so in CQL, what they did is they separated this, so they just tell you the valid encounters, and then after this, they tell you what the valid diagnosis is. And so CQL is intended to be cleaner for this. And so just to recap, some of the things, there are a few main categories where CQL might be beneficial. So one was around the temporal relations and encounters, which I just showed you. So in CQL, right, they would say starts 3 months before X, whereas in the QDM, HQMF-QDM, they say greater than 3 months starts before start of. And the start before start of is something that's not very clear. And so here's a good quote. If the encounter diagnosis was present for more than 2 years, I couldn't do that in QDM logic. I would have to say the diagnosis was present for at least 2 years before the measurement period, and there was an encounter diagnosis that's the same thing. Now, in CQL, I could just say the encounter diagnosis started more than 2 years ago. So it's a lot cleaner. From the authoring side, changes to the QDM helped the CQL, and the CQL helped tremendously to be able to create those expressions and make it cleaner. Another potentially beneficial aspect of CQL is around readability. So more subjects tended to note that CQL was simplified and easier to read, with clearer naming expressions like the age in months and age in years, for example, and an improved visual aesthetic. So here's another quote. So this person initially is talking about HQMF QDM, says, so looking at the indentation, I forgot that one of the things I disliked and personally found confusing was the way that they put ands together and the or indent. To me, it's kind of hard to unwind and reapply that at first glance. And the fact that it starts with and, the initial population equals and that, and that, and that. And I think if it started with initial population equals patient characteristics, etc., it would just make it a little bit more natural language as you're reading through it. And so then he actually, hearkening back to the way that they did age and months, I think it's a lot cleaner than the way they represented as part of the demographics within CQL. However, again, there is disagreement. So this is a quote that directly contradicts the quote I just read. So, in the quote I just read, the guy did not like the fact that you had it started with an and you had and that, and or over and over again. However, in this quote, this participant said that, I guess it's clearer, so you kind of flipped it upside down. The numerator and denominator are towards the top of the screen. At the bottom of the screen, you've defined all the data elements. They have and at the top. That's really clear. The initial patient population equals your criteria, although the logic's still not super clear. Denominator, initial population exclusions, a bunch of or statements. I mean, the two main differences that I see is that the elements of the thing are more spelled out. They're more wordy, so they're more descriptive, so I don't have to reference their definitions to know what they are. So this person likes that HQMF QDM is wordy, whereas the other person liked that CQL was cleaner. So CQL has all these functions and identifiers that are intended to be reusable components across measures. So you can define something like children aged 3 months to 18 years once, and you can just use that across 10 different measures, for example. So people like this. This quote, the person says that not that pediatric age takes a lot of time to rewrite, but you can set it up once and reuse it. So I know that if we had to write this every time for a different measure, it might be redundant. However, people don't understand all the different components within CQL. So the takeaway is that people might need more explicit documentation to understand some of these things, like the reusable components. So here, this person is making the assumption that there are complex data types, how it does typing, how CQL understands the concepts of time and date and integers, exploding point values. And so here, what they want is they want to know how these things specifically tie into clinical quality measures. And this relates to some of the results when I asked people about the policy and regulatory and environmental issues that they needed, or not issues, but resources that they needed to help move CQL forward. So this person says, I mean, to be fair, you're coming from an existing understanding of things. So it's a matter of explaining your knowledge of HQMF, and here's how we're different and better, what the goals are and how it meets those goals. And not to diss HQMF because it works great, but this is just a different way of looking at it and how I think differently about this. Then separately, honestly, examples, 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 and stepping you through examples so I can understand that, because that's how I learn things. And so there are some existing resources that CMS and the CQL community has put out to try to address these sorts of things. There's the Measure Author's Guide on the eCQI website that talks about CQL formatting and how to use it and what some of the different functions and statements mean. And there's a usage wiki. And then they have monthly webinars called Cooking with CQL. And then there's also a Developers and Authors Guide within the CQL specification. However, people are asking for more. They're asking for more explicit documentation. So some of the implications of these results are that what we learned is that there's this paradigm shift. People have up to 11 years, almost like, a decade experience with HQMF QDM. And so therefore, even though there are things that might not be perfect, they know what the components mean and how to decipher them. There are also a variety of tools, like the measuring authoring tool, and Help IT vendors themselves are able to read HQMF QDM and facilitate their validation or their implementations. And so what the the community needs is they need these tools to be updated to also be able to work with CQL. So I think one of the more beneficial aspects of CQL is that it's intended to be more general, and it has these reusable abstracted components or these libraries and functions that can be shared across the measures. However, one challenge with this is that if there is an error in one of these functions or libraries, then it can propagate. So if you make the error once and you apply it to 10 measures, you now have introduced an error in 10 measures at once. Another factor that we found is that with HKMF QDM, you don't really need to have programming experience to be able to decipher it. It's sort of just this Boolean logic, so if you have any experience with that, you can sort of figure it out. However, with CQL, I think that having a technical background or experience in programming can directly help you readily use and understand CQL. So in this study, all 13 people sort of had that experience. And even with that experience, their interpretability varied for CQL. And so there's no annotation currently in these CQL examples, so I think that's going to be really important, especially as we think about the clinical users or non-technical people that'll be reviewing CQL. And so that's all sort of technical within expression logic, but then also thinking back to some of the stuff I showed you about the patient safety and population health. If CQL is not better at increasing the portability of the ECQM measure specifications, we might be, we're not as effective at increasing population health and then also increasing the comparability of performance across sites that we can tie to payment. So in conclusion, our subjects tended to agree about the enabling factors and challenges related to ECQM logic criteria. However, they disagreed about the specific ways that these might be resolved in logic expression in CQL versus HQMF. So while CQL is intended to be better and it might have more of this formal structure and grammar, there are still prevailing challenges in delineating ECQM logic that might still exist in CQL. And so as a result, implementers might continue to have to handcraft and make these local decisions in uncertainty based on their clinical knowledge and their intuition. So moving forward, I think we need further training materials, community forums, and these examples to help with the new paradigm shift. And so specifically thinking about the curly brace problem, is CQL a step forward towards addressing this? I think kind of. There are these issues around temporal relations and readability, which I think are especially promising. However, at a basic level, if you were to just think about the issue, which is that you have to take these definitions and then map them manually to an EHR database table or field, like that problem still exists with CQL currently. So some suggestions are, one, for this problem around propagating errors is they need some sort of validation tool or some type of evaluation for people to be able to point these out and vet for errors. And then secondly, I think the call for examples and annotated files is particularly useful. I think especially one that's clickable, like if there's this function age and months, maybe a hyperlink, you can click on it and it takes you to the guide that clearly defines what that actually means so that there's less ambiguity. Because that's the goal, is to abstract these things down so that in CQL so that it's very clear, so that then you can take that and create programming code. So for future work, I think more evaluation of CQL is needed, specifically around interpretability, and I think more training needs to be implemented in the workforce so that people know how to decipher these things. And then more efforts to standardize the structure and eliminate errors. And then importantly, the goal is that in the future, this expression logic model can have a machine that interprets CQL, and CQL can be machine readable. So while there have been some models of this at Mayo that I described with FHIR and semantic web technology, I think there needs to be more efforts in that so that we can get to this standard portable, interoperable ECQM ecosystem. So with that, I'd like to thank my committee, Dr. David Dorr, Nicole Weiskopf, Aaron Cohen, and Steve Bedrick, Dr. Frank Naimi Rad and Teresa Kepik provided me with funding through a scholarship to support some of this work. I'd like to thank Diane for answering all my questions, and yeah, I think I'm ready for Q&A.
So this was super interesting. I should disclose to the audience members I was a subject in the study. How do you see, how does SQL handle those global variables? I guess for lack of a better term for them. So those things that you could potentially recycle through multiple measures, right? If a measure author sort of creates one and then puts that out across measures, it's not, in the current state, that's sort of because you don't have that, everything's defined in that specific measure. But when you have things that are now defined outside the measure, it almost feels like that stuff needs to get housed somewhere as well. Has that problem been worked on?
No, as far as I know, there's just this guide. It's actually very good documentation. But that's part of the problem. That's what people are asking for, is something like that, this essential, more than a document, something like where all those functions are clearly, explicitly defined.
Yeah. And then my second question is, do you have, in talking with all these folks and doing the research that you did you get a sense of why CMS sort of moved so quickly to make this their standard, right? Because in 2019, this is how they're going to publish all their ECQMs, and it feels like it happened fairly quickly. CMS isn't often known for doing that.
Mm-hmm. Yeah, I think it's because HQMF QDM is not that good, and that the variation that I talked about in the papers I've written is actually pretty well understood, or at least acknowledged. Dave also wrote a paper a number of years ago talking about the inaccuracy and complexity of different measures as they moved, right when they moved to HQMF QDM. So even 10 years ago, they rapidly implemented HQMF QDM. There was that variation in uptake, basically. And so they're hoping CQL will help, but there might just be also variation in the rapid uptake of CQL.
So it just occurred to me that there's going to be some opportunities for doing kind of a natural experiment as people switch over. Mm-hmm. And I mean, I guess you're kind of wrapping up, but I was wondering if that's something that you've given any thought to, whether there's actually an opportunity to see what impact that switch has over towards the CQL and how you would do that.
Yeah, I have thought about it. It's sort of tough. There's so many confounders, right? Because I guess for a measure where the logic like really changes, or they make like a big change to the definition, I think that would be more interesting. But if it's a measure that stayed sort of consistent for 5 years, someone who's implemented that measure doesn't really need to study the pseudocode anymore, right? Like so you've implemented it once, you might know the relationship between the denominator and numerator and exclusions, and if there's just minor tweaks over time, you've already sort of mastered that. So I don't know if this switch from HQMF to CQL will really matter all that much. But if there's something big, like they add a whole new, some of these measures sometimes will split into having from one denominator to 2 or 3 or something. So I think for those, yeah, you could do something like that. But again, it's hard to control. Especially because what we're talking about, right, is the human craft intervention and handcrafting. So I think you would have to do like a qualitative aspect of it too and ask them, did you use the pseudocode, or how they went about implementing.
So the natural experiment would be really cool, but it sort of assumes that there's some automation in using the CQL, so the CQL then produces this other measure, and we compare the CQL-generated measures with the old measures, and that would be really interesting to see what kind of changes there are and whatnot, but I think appropriately the answer Raja gave is that this is right at this level of technology. This is all just documentation for how to implement the measures, and if they've already implemented the measures, so I guess I'll turn the question back: is there, for measures that are new or highly revised, like you're saying, maybe with the phasing in of CQL, there could be a natural experiment, because there would be some people who would be implementing the measures based on the old standard because they haven't gotten there yet. They haven't taken the courses or studied online, and then other people maybe are, farther along in, the early adopters versus the late adopter kind of thing.
Yeah. Or you could do it with, people like me, I guess, a couple of years ago, before I ever implemented a measure. I was brand new to HQMF. You could sort of randomize that. Show some people that really don't know what they're doing, and you assume that they have equal experience or something. Show one group HQMF or one group CQL and see who gets it right. Yeah, that could work. Yeah.
Just along those lines, the demographics of the 13 people, was there 6 that were authors of ECQMs?
No, it was only 3.
3.
It was 6 had experience with CQL and 6 had brief understanding of CQL. But 3 of the 13 had authored measures.
So I guess my question is around if they've had experience authoring. I'm just curious in the responses to which was easier, the CQL or the the form.
HQML.
Yeah, thank you. What is my question? The people who've had experience authoring, which one did they like better? Which was easier for them? But that's kind of around that same testing if people have had experience with the form.
Yeah. So, I think your question is there's authors who've used CQL. So what was their feedback on the interpretability? Because they've helped create it or they've used it.
They've had experience.
Yeah, they've had experience with it. So I actually thought that before talking to those people, sort of went in thinking oh, okay, these are the people that have more experience, like you say, with CQL. And there was actually one of the subjects broke down to me the difference between writing versus reading. He was kind of meta about it. But he was really helpful, and he was talking to me about the differences. When you write something, you just assume that it makes sense, right, as opposed to reading it. And so interestingly, though, even those people who had experience authoring did not think that CQL was better all the time. Especially when I showed them CMS 154, a couple of the people actually worked on authoring that. And they still were confused. And they made it. So, it varies. Even for that group, it varies.